migraine, if anything, actually runs on my father's side of the family. I don't believe that anyone, maybe a cousin on my mother's side of the family experiences migraine, but on my father's side, we have many people. My father actually has migraine with aura, and I would say probably my first few attacks were when I had a gap year and I was traveling abroad, and I really didn't even know what I was experiencing, but I knew that I just kind of had to lay down in a dark, quiet room. And for me, it wasn't even so much the nausea or the actual headache pain. It was more of a severe spinning vertigo sensation that lasted a little less than an hour. And then, the many of the headache symptoms would really start to um, um, uh, present themselves. That's what my typical pattern looks like. Although I will experience some primarily migraine without aura type attacks. The majority of my attacks do precede themselves with pretty severe spinning vertigo, kind of clues me into exactly what's going on. There have been rare circumstances where it's happened right in the middle of a workday, and I, have to stop everything that I'm doing, and I know that I can't see people as a physician if the entire room is spinning, and if I really can't focus and appropriately provide the level of care that patients expect and that they deserve. So sometimes I apologize if we ever have to reschedule because of something like that. Just realize that it's so that way you can get better care when the time is appropriate. There have been times when my frequency has been higher, sometimes when it's been lower, rare times when I've needed more than the lifestyle modifications and vitamin supplementation, where I've actually put myself on different, preventive, medications, and sometimes acute therapies, can be for me the thing that determines how quickly I can bounce back or not. So, we always say doctors are the worst patients. It's 100% true. And we kind of rely many times on talking to each other about what we're experiencing, and managing. But that's what my experience is like.
Right. I really appreciate you sharing that. And I will say that besides seeing you, I've seen one other headache specialist who also has migraine himself. And the two of you were easily, they've been the best experiences for me in talking with a doctor about what I'm going through, because there's that comfort level that I know that you know. And I know that you don't think I'm making something up if I talk about it. And the same would go for any man that you see and any other patient that you see as well. And so while obviously I would never wish migraine on anyone, I think it's really amazing that someone like yourself has chosen to come into this field and help people who live with this disease and live with it yourself and are willing to advocate and talk about it as well. And that's really amazing. So really appreciate you doing that as well. For those who know me or know that I live with chronic migraine, I also have three sons, and all three of them have migraine as well. They have all had migraine in different kind of presentations. One of them started at age 9, and most of his adolescence was spent in hospital and in bed and had to drop out of high school. One of them started also around 9 or 10, but was not too bad. It was more easily manageable. And then my youngest, it really started to kick in after COVID. So I am very passionate about this topic and about talking about men with migraine and what can we do to help break that silence and let men know that it's nothing negative having this disease. It doesn't make them less than or anything like that. It's just a disease that they didn't cause. So maybe we could start with some statistics. And I do see that a couple of men in here who have migraine were commenting they also get vertigo. One of them was saying that they find it hard even to be in a car driving, that can really impact that as well. Is that something that impacts you too, Dr. Berk?
Well, safety is the number one priority. It has never happened to me that it's occurred like when I've been driving, thankfully. But you wouldn't want somebody who starts to develop, vertigo on the road while you're driving. It certainly
Right.
would be unsafe. And usually there's somewhat of a premonitory something. Sometimes it's just the vertigo, but sometimes there's a prodrome, there's something that you're experiencing that can tell you, you know what, I need to go and take something, somebody else drive right now, wait until it is a safe time. Certainly if I'm not
Right,
gonna be seeing patients, I'm not going to get behind the wheel,
right,
of a vehicle. It's quite different than the laws that relate to having epilepsy, somebody who has seizures, with driving, where there are states that have mandated reporter laws. So, for instance, some states like New Jersey, if a neurologist sees a patient that has epilepsy, they're mandated to report them to the DMV based on
right.
what the seizures were like, loss of consciousness, how frequently they happen, etc. It's not like that when it comes to the majority of other, conditions where you're not losing
Right.
consciousness.
Right, absolutely. I hear you on that. And I should also say that my husband actually has what was diagnosed as retinal migraine. I rarely see him with it, but when we were dating 80 miles apart, and he told me one day, when I was on the freeway, I just lost my vision. It just went out. He had promontory, that kind of, he knew it was going to come, but he said, I just completely lost my vision for a few minutes. Obviously, he had to pull over and stop. And I think that's a concern, obviously, not just for men, but for women, to make sure that you recognize the signs of an attack starting. If you are operating machinery or driving a car, just know what you need to do, and to recognize that, and take adjustments as necessary. So why don't we talk about how many men with migraine, how many men there are with migraine in the US? We know that there's at least 25%. I have this theory, it's not scientific. I mentioned it to you before, Dr. Berk, at a conference. Maybe there's more than 25% men, because men are less likely to be diagnosed, or they're more likely to drop off after adolescence when they leave home. Is that a crazy thought, or is that possible? Obviously, I know we can't prove that right now.
Totally accurate. That's 100% accurate. It's something that we know, it's something that we see. We know that that's the case with the majority of men's health disorders, that oftentimes people will, wait sometimes until it's, well beyond, an appropriate time before they, finally, get evaluated, get some kind of treatment. We know that, men generally, they will go longer without seeing a physician. They will, bear the symptoms for longer periods of time. They'll be less open to talking about it, even with family members. So sometimes a person can just see, a loved one kind of grimacing, or they're not sure exactly what's wrong. And even if they try to ask them, they may not necessarily be so open about it. It is definitely the case that because of that, most men's health conditions, but certainly migraine in men is vastly underreported.
Right, absolutely. And that's such a shame that it is. I understand that. I see comments again in the chat going, why do people think I'm faking all the time? Another man here says, I think the general public, they just see migraine as just a headache, just simple, something that they experience themselves, and you should be able to deal with yourself. Um, so I mean, obviously this is a common experience. Why do you think, though, that people still see migraine as a women's disease, even with the numbers as they are, 25%, that's a huge number of men who live with migraine. So why is the messaging still coming out that this is a women's disease? And many commercials and the ways of marketing are aimed at women rather than men.
I think it's just because it is 3 to 1 women to men, and especially during reproductive ages, that's really where it peaks. And you see it being something where, overwhelming demographic is going to be a female demographic of people who experience migraine. It changes, and I know one thing we're going to talk about is it changes over time. What we see is kids that are in, early grade school age, maybe 6, 7, 8, the, pediatric headache specialists that see, children, it's about 50-50 boys and girls.
Right.
In older adults, there may be a trend towards it being slightly higher, even in men versus women, maybe related to, neck, in addition to, migraine issues and them tying into each other. And many women, as they get, to and through, not It's not the case for everyone, but for many women, once they get through menopause, the hormonal fluctuation that triggers migraine isn't as much of a factor. And if anything, because there's that, trigger that is not at play at all, oftentimes the frequency can be significantly lower than it was, when, at other times. Many women who experience, who have, a lower frequency during pregnancy and during breastfeeding are the kinds of women that tend to do a little bit better when they get through menopause.
Yeah, that's interesting how that changes. Do you think that, or in your experience, do men, whether they're, young, whether the kids or adolescents or adults, do they tend to experience the same symptoms as women at the same severity? Is it pretty much there's no difference between the sexes, or do you tend to see more of one thing in men and another in women?
For the most part, I don't think that we see that the subtypes of migraine are vastly different when it comes to men and women, as much as it is the incidence of migraine in general. So there doesn't seem to be a huge difference when it comes, if you're factoring in general the frequency of migraine when it comes to vestibular migraine, migraine with or without aura. We don't necessarily think that there is a larger population of women within what that population size would be, looking at those specific subtypes.
Right,
That being
interesting.
said, the studies that look many times at these subtypes are very small and may not be representative of the population as a whole.
Right, and that's always frustrating when I see articles in magazines that are quoting a recent study or something about a new treatment or something they're finding out, and you see, or there was only 8 people in the study, or there was only 20 people in the study, right? And there was no double blind, there was nothing else, and so it can get frustrating, that's for sure. So looking at men being less likely than women to go to a doctor, is that how much of an issue is that in the treatment and the management of migraine, do you think?
I think it's a huge problem because I would say the number one reason why people don't go to the doctor is because they don't think that it's going to be a helpful experience. Either they've had bad experiences going to the doctor previously, or they think, I'm going to go there. I'm going to tell them that I experience, this issue. What are they going to tell me to do already? There isn't a cure. There probably isn't anything that I can do. They're probably just going to tell me take aspirin and call me in the morning or something like that. So I think a lot of it is, a lot of our jobs as headache specialists is to educate our patients just in general about the fact that there are options. Many people just don't know that there are things that you can do that range from taking medications to not taking medications, lifestyle modifications, supplements, things that you can do that can be, very meaningfully helpful. And sometimes it's just knowing, by the way, that there are people that are just like you, that are struggling and trying their best despite having this major issue. Sometimes that, removes a lot of the shame, the stigma that they have. So not only, do they not talk to their primary care doctor, usually they're not talking even, they're not going to see headache specialists. They don't know that such a thing, exists at all.
Right, absolutely, I hear that. So I just want to address some of the comments that we're getting coming in as well, that this Men with Migraine project, it's not just this webinar. So I don't want you to think that this is it. Maybe some of you thought you could chat directly with the doctor. We can't do that in a webinar, but we can answer your questions. So if you put questions in the chat or in the Q&A, I would definitely ask Dr. Berk those questions. I also want to let you know, if you're not already signed up with this project for men, we are going to be doing focus groups because we want to hear from men. We need to hear from men. We need to know about what your struggle is and what you're going through, what your perspective is on this disease, the way that it's talked about in public awareness and stigma. So I would definitely encourage you to please sign up for that. Our focus groups are hopefully going to start this week. And there are also other opportunities besides focus groups, one-on-one interviews, a panel that will just be men as well, and then obviously social media opportunities. So if you're not signed up, please, I would encourage you to do that because we want to hear your voice. It's so important. So Dr. Berk, just I'm wondering what would be your response to a recent statement from a young man with migraine? And he said, you have to tell them what is going to happen. And that's referring to the young men. You have to tell them what's going to happen. And young men don't like to accept the consequences of that, but they still need to hear it. The same as we're told about the impact of smoking and alcohol. The bare minimum that needs to be done for men is that they have to be informed about migraine as a progressive disease and the consequences of ignoring symptoms or just trying to tough it out. And that is word for word verbatim, a quote from a young man who lives with migraine. What is your response to that, Dr. Berk?
I think that that's 100% true. I think, just like I was saying, um, most people, not only do they not know that there are options, they don't even know what they're experiencing. Right? You're talking about providing a diagnosis. Um, as I train, I've trained medical students and residents, oftentimes training NPs and PAs, sometimes, to, a somewhat more, different or unique, perspective when it's, via telehealth. One large segment, probably a third of the appointment, should be, now that you've told me this is what we think you have, and this is why. And part of that is, this is the definition of migraine. How many people that are even listening to this webinar have ever been told, by the way, this is what a migraine is defined as. This is what having a diagnosis of migraine means. You fit these criteria. And this is what migraine with aura is, versus without. The natural history, you talked about it being progressive. If, just sometimes the words, more migraine begets more migraine, being on top of, increases in frequency, so you don't end up much, much, worse, can make all the difference in the world. So being sometimes just on top of it can be very, very helpful.
Yeah, that's interesting. It was good to hear from that. And we do have a question from someone here who's asking, do you think migraine specialists or providers are on the rise? We all know there's not enough, certified headache specialists. He's saying he lives in Tennessee, and last he checked, there was 2 specialists in the entire state. Are you seeing more and more doctors specializing into headache medicine, or is that still a really tough area to get people into?
I think it's, difficult. I think that sometimes there are even large population centers that are extremely underserved when it comes to, headache specialists. There are, different certifying, boards when it comes to, headache. So there's, the UCNS, which is like a formal fellowship plus, board certification. There's also something from the National Headache Foundation. Both at least will, allow you to find somebody who has an interest in not just learning about headache, but seeing patients with headache. They appreciate what the patient itself is going through. Like that's what that kind of self-proclaims. The fact that there are so few people is the reason why, we do think even before the pandemic, telehealth existed on actually a national level. Many people don't understand the first large, telehealth program was the Veterans Association. The VA, had and continues to have a system where veterans, especially in more rural areas, would be able to see specialists very, very quickly. They could, at that point, it was really going to their local VA, which, is closer, but they wouldn't necessarily have, forget about a headache specialist, even a neurologist, they'd be able to see people that way. So, recognizing, the fact that there are people that can help, and that, there are ways, to get to see these people. Oftentimes, I'll tell you, nowadays, maybe primary care doctors know a little bit more sometimes, even with regards to like the CGRP medications. where, 10, 15 years ago, I don't know that they would have been interested. They would know about triptans, and maybe they'd put, somebody on the most basic preventive medication, but that would pretty much be it. And now I have primary care doctors, colleagues that I see, they're starting patients on Qulipta, they're referring patients for Botox, they're giving patients injectable, monoclonal antibodies and giving them migraine specific acute medication. So I think that there's somewhat more knowledge, and sometimes starting with what you have and working up from there and seeing, if that is something that's helpful and effective.
Right. No, that makes total sense. And also just want to let people know, maybe someone could put the link in the chat as well, that we do have a headache specialist website with a database. So everybody who is certified with UCNS or the AQH, and some people have both certifications, it's actually just in the process of being updated. So it's already live. You can go into that headachespecialist.net and also headachedoctors.net. So you can go to that website and you can do a search by zip code for a specialist. And if you come back in, hopefully within a week, we'll have taken all the updates and actually uploaded those as well. So I just wanted to let you know about that resource. We have someone here who's asked a question. He says, what do I tell someone when they think I am faking a migraine? So he's not being specific about a doctor or someone else, it's just general advice. What are your thoughts on that?
Migraine is one condition out of many that, we call in these invisible conditions. You're not walking around with an ankle, splint. And if you were playing basketball over the weekend and you twisted your ankle and you walked in with like a little boot, everyone would be like opening the elevator door for you. They'd be holding, oh, could I get this for you? Meanwhile, you could be experiencing something that the World Health Organization has estimated as one of the most disabling conditions that people can experience, especially during the condition. There isn't something that you can do. The more that you try to do, the worse that you get. And people look at you and they're like, I don't know, you kind of look like yourself. Maybe your eyes are closed, maybe you're in a dark, quiet room. Oftentimes, we're not seeing them in those situations because they're trying to get away from everyone when they're really not looking well, especially when it comes to men who are struggling and are in the midst of an acute exacerbation. They don't want anyone to see them. There's somewhat of a pride at stake. There's even more stigma than that there sometimes is in other situations. So it's, I think, many times probably not appropriate to like give them something, kind of pithy, and say, well, I don't know what you look like when you're, but at the same time, you can say, I understand that. This is what's considered an invisible illness, but it is extremely disabling when I experience it. Migraine is more than just a headache, which is something that we've been saying for a little bit. And when I experience it, there really is nothing more that I want to do than get back to, me being myself again, but I just can't.
Right. Absolutely. I totally hear you on that. So a question about treatments. We're not asking many questions about treatments here, or we didn't have many questions, but we've had a couple come in once before and once right now. So in your practice, do you find that there are specific treatments that men have greater success with versus women? Or is it pretty much, I guess this kind of goes along the same lines as like symptoms. Do you see that, or is it really everything just has to be personalized?
The only difference I would see is something very subtle, which is sometimes side effect wise, there are people that would say anecdotally, certain side effects are maybe a little bit more prominent in some people versus others, whether it's male versus female, that could be sometimes part of it. One commonly used blood pressure medicine that's helpful preventively for migraine is one that's called lisinopril. Lisinopril is associated with the cough, and these ACE inhibitors are more associated with the cough in men than they are in women for whatever reason. So that's one thing potentially to consider. Side effect wise, I would say many of the GI associated side effects like constipation, when it comes to Aimovig, which has a warning on that, I would say it's more female than male. And then the opposite is true when it comes to the other, warning on the monoclonal antibody, CGRP medications for blood pressure. I tend to see that the people where the blood pressure really does get affected are usually the men that are, kind of middle age-ish. They're in their maybe 30s, upper 30s, younger 40s, And around that time, they might start to develop high blood pressure. And it's that these medications really kind of unmask it a little bit. They bring it to the forefront. So that's what I would say. I look a little bit more closely for blood pressure changes, especially high blood pressure. I'm starting a CGRP medication on men, and I talk with women a little bit more about
Right.
GI side effects. That being said, you have to, definitely address these issues and concerns in both populations.
Yeah, no, that makes total sense. And it's also fascinating because I find that fascinating that you even see that subtle difference there. So we had a live question. It says that they see a lot of commercials for CGRP medications. But the hot question, and this is obviously not just for men, it's for women too, is what new medications or treatments are being developed for people with chronic migraine? I know there are a lot of options, so maybe you could just kind of hit the key ones, or especially the ones that are, in phase 2, phase 3 that are coming up quickly.
The things that are coming up a little bit more quickly are going to be number one, people are very interested in preventive medications that are blocking a different neurotransmitter called PACAP. There are two different subtypes of it. There's a question, and the studies are actually looking at these two different formulations. Is it best as IV or as an injectable? There are very early stage um, um, there are early stage studies looking at GPAT type medications as injectables. So, for instance, something that's like um, Nurtec or Ubrelvy or Ubrogepant, but using them acutely and completely avoiding the GI tract that way. Um, Recently, a few different formulations of dihydroergotamine have come out. One that I'm personally somewhat, involved with is Brachia auto-injector, the DHE auto-injector, which is coming, soon to market. There's also an intranasal powder, and there are a handful of, other formulations. Some are the generic, just kind of like intramuscular, ways of doing DHE. There are a number of studies that are looking at non-migraine specific, type treatments, how they relate to migraine, speaking to some of the people, for instance, over at Jefferson, maybe additional publications as it relates to ketamine. Low-dose naltrexone is something that a lot of people have been talking about, and is getting a little bit of a closer look at also.
Oh, that's really interesting. So thank you for sharing that. And I know that myself, pickup is something I've got my eyes on because I know it's coming up
Absolutely.
quickly, right? And I'm sure a lot of people are as well. We have a comment from someone here. It's Brian Bailey. Actually said he just finished his dissertation. So he did a dissertation on chronic migraine on stigma for men, specifically in construction.
Oh,
Just comments, yeah, very specific and challenging as well. It's difficult for them to receive accommodations or even disclose their disorder for men who have migraine, who work in the construction industry. Many don't even have the slightest of benefits, such as paid time off or sick leave. He's just making a comment rather than asking a question, but he does go on to say that it greatly impacts their quality of life at home and at work. And so it kind of brings me back to a question I have, which is, what is the best way to communicate the impact on life that migraine is having as a man? Because we know that obviously it's not just I get migraine this number of days, it lasts this long, I take this medication, but how is it actually impacting your life? What is the best way for men to communicate the huge impact that this disorder can have on them sometimes?
I would say the most important way that they can communicate this is sometimes by being a little vulnerable. It's very hard. It's very, very hard. Um, you know, uh, Expressing to people sometimes that they do need help. Um, Many times, in these situations, I think Brian is 100% right that um, it's different than somebody who has desk job. It's different than somebody who's working remote. It's different than when we ask accommodations when, patients come to us and say, there are a handful of, things, maybe they have an employment lawyer that's involved already. It's a very different situation when, whether the, title of the person, is, VP of something or even, director or associate, whatever, versus the person is out in the elements, sometimes exposed to environmental things that may be worsening their attacks, it's very, very tough to find ways to potentially work around it. I do think for the most part, there are usually some legal avenues that are available for these patients that we don't always observe or realize immediately. And hopefully we will be able to advocate. I'll tell you, headache specialists, this is what we spend a lot of time doing, advocating on behalf of our patients one way or the other.
Yeah, absolutely. I hear you. We actually have one gentleman who he was actually the first man who answered our call for men with migraine a few years ago. We've worked with him several times, actually done several videos with him. And he was in the communications industry, used to have to climb telegraph poles. And he'll say, you can't do that when you're throwing up from a migraine attack. It's not even can't I? You cannot do that. And he had to get out of the industry, and find another career that hopefully will be more easy with migraine. But it's such a challenge. Obviously, it impacts every aspect of men's lives, every aspect of everyone's lives if you live with this disease, and the career is definitely included in that. We did have a question before the webinar started, and it was specifically about going to the gym or exercise. Are there specific activities that tend to trigger migraine attacks more than others, or activities at the gym that do that, or that will worsen an attack?
Number one is when you're not during an attack, exercise is very helpful preventively for migraine. A regular exercise, 30 to 45 minutes, 3 times a week, has been associated with, almost as direct of a benefit as some preventive treatment options. So the first thing I would say is if you can be active, it's very, very helpful to be active in one way or the other. For some people, that might just be, walking around the block a couple of times, a few times a week, and that's great. And then you can kind of work up from there. For some people, that's more. There are specific kinds of headache. There are headache subtypes that some people can have that are associated with activity that can trigger an attack. So there are a handful of what we call other primary headache disorders. In other words, they're not migraine, tension type headache cluster, but they are, in this, there are 10 different, and there are subtypes of them. And, there are some that are triggered specifically by exertion or exercise. There are some that are triggered by any kind of exercise, and it's more a reaction to heart rate being elevated. For some people, it's related to lifting specific weights. So there's a weightlifter's headache, which is a kind of exertional headache. In general, if it seems like some kind of exertion worsened your headache rapidly, and it went from 0 to 10 within 60 seconds or less, that is a medical emergency. You need to go to an emergency room immediately. That being said, during an attack, you're not going to want to do very much. You're not going to want to walk around the block. You're not going to want to walk up a flight of stairs. A hallmark of migraine is that it necessarily worsens with physical exertion during the attack.
Right, absolutely. And I appreciate you saying that, because that's another factor. If you want to keep on going when you have a migraine attack and feel like you just can't, then obviously it's more easy for you to feel like I should be able to pursue, I should be able to do this. But most of us are, well, maybe I should say many of us with migraine, men and women, know that exercise of any kind is going to make our attacks worse, which is one of the reasons it's such a disabling disease. We did have a question on a different type of treatment, which is PFO, so patent foramen ovale. Not sure I'm pronouncing that right. The PFO closure. Is that something that that you will recommend for your patients or not?
There's definitely an association between having a PFO and having migraine with aura. The relationship isn't completely understood, but I'll tell you, in the early 2000s, early 2010s, it was very popular for people to undergo closure of their PFO to see if it improved the frequency of their aura attacks. Now, the main indication for closing a PFO is stroke. So if somebody has heart, a clot in their heart or somewhere else in their body, if it can move from one chamber of the heart to another, it can go directly to the brain. So that's a reason to potentially close it. Otherwise, if it happened to be caught for, for other reasons, a person just underwent, an echocardiogram and they saw it, generally they won't close it. We were closing many PFOs over that period of time. I'd say probably from, 2005 to 2015. And a retrospective study that looked did not see that there was an improvement in the frequency of attacks, either, painful migraine attacks, aura attacks, and didn't even seem to show any difference with regards to, there was a question, maybe it had something to do even with white matter, changes, these, T2 flare hyperintensities that we see in migraine on an MRI. So right now, we don't generally recommend getting a PFO closed for migraine. There's another indication, sure, but it just doesn't seem like they are, appropriate treatments, effective treatments.
Right. Interesting. Thank you. So we had another question that came in before the webinar started. It was actually in an interview, and the man was asking, what is the best way to address scapegoating or stigma from a doctor where migraine is blamed on lifestyle choices or risky behavior and the actual disease is not addressed? It's not self-addressed. For example, the doctor may say you're drinking too much caffeine, you are smoking, or you're not exercising enough, all of which could impact migraine, obviously. But when the disease is not addressed, how do you communicate with a doctor who's doing that? Or is that really time to say, okay, I'm going to go see another doctor?
I mean, I feel bad saying, give up on your doctor, especially if it's very difficult to find someone else. But if it sounds like your doctor's kind of given up on you and is not providing you appropriate care, that might be the case. The reason why people experience migraine is not because of something that they did. It's a genetic predisposition that they have. Most of the things that are triggers for migraine are part of life. They are unavoidable. It is rare for, someone to only experience migraine because of a specific, let's say, food trigger, and they keep really wanting that specific food trigger. 9 times out of 10, the reason why you're experiencing an individual attack, even with triggers happening, is that there's a constellation of triggers all happening at the same time. Sometimes there can be even medical causes that primary care doctor may be, completely and totally ignoring. And maybe they are saying, well, your B12 level or vitamin B, D level, they're a little low, but I see people that are low all the time. And it's very important to realize that those things can be a significant factor. So if they're telling you that it's all your fault, I think that it may be time to, move on and find somebody who really understands something and knows something when it comes to migraine.
Right. No, that makes sense. And we hear people in our communities all the time saying how their doctor has fired them for one reason or another. But then they'll come out and they'll say the things that their doctors are saying to them, and it's horrific. So I think it's important for people who live with migraine, whether you're a man or a woman, to know that you can fire your doctor. You can go find another doctor. It's not always easy to do that, obviously, which I think is one of the challenges. Do you think that there is an innate belief in the healthcare system and society in general that men should be, quote unquote, able to handle it?
I think that that's a problem with, a lot of, I would say it's a notion that a lot of people have, whether they express it or not, in their, in the back of their mind. It's something that is unhelpful and unhealthy, in general, right? There's this phrase that people use, oh, you gotta man up. But what does that mean? Everyone, has an idea of what that sounds like in their mind, and it means sometimes you have to do things even if it's impossible. And sometimes, by the way, doing the thing even though it's impossible is actually a really terrible idea, and it in the end makes things a million times worse. Sometimes it's, men even being vulnerable to the people that they care about, or to, like we mentioned, even a medical professional, and not actually getting an empathetic response, not being educated with regards to what it is that they're experiencing and not being told that there are options, there are treatments, there are things that you can do.
Right, right, absolutely. So I'm going to talk about a phrase which I didn't know, hadn't heard of until this week, but we talked about it before we started this. So it's like the ick. And so, I want to ask you, first of all, I know you're familiar with the term because you told me this is the term often used by Gen Z.
Oh
Can you
yeah.
explain what the ick is and how that has an impact on people who live with migraine, or men who live with migraine?
The ick is something that a lot of people use to talk about, let's say, something that they may see or experience on a daily basis that turns them off, makes them rethink, their relationship with someone, things like that. And one thing that I'll tell you is men would definitely be afraid that them being vulnerable or having almost any, weakness, shortcoming would be an ick for those that care about them and love them. And the truth is that if they love them and care about them, these are people that, understand where, that man in their life is coming from. And sometimes they are the people that need help. That being, it is unfortunately a contributor, whether you call it the ick, whether you call it, just not feeling that you're macho enough or man enough, that creates itself a lot of stigma. We're talking a lot about stigma and the worry of, what happens if I say something about this? Is that going to, come back and negatively affect my life?
Right. Yeah, absolutely. And I can only see that being really aggravated by what we see in social media nowadays, and that it's easy for posts to go viral. And if there was a post that's talking about the ick that's relevant to
Oh,
migraine,
yes.
right? It's just, I don't even know what you can do to address that, except that one of the things that as an organization we are trying to do is create social media videos and posts that hopefully will ultimately go viral the other way, where we have men talking about what it is really like to live with migraine. Yeah. Is there any other way that you think that, that can address this, or is this just something we're going to have to learn to fight in different ways?
I think that a lot of it is, marketing teams when it comes to, migraine, working on showing men, not just women. And I think that more recently, many of the marketing campaigns have, at least secondarily, and sometimes even somewhat more to the forefront, have shown men, which I think is somewhat helpful. Part of it is what do you see, whether it's in social media or pop culture? A lot of times uh, when you say migraine, the thought in the back of your head, just because you've seen it on TV shows or whatever, is, a woman with,
Right.
her hand over her face.
Or the
And for that champ, for instance, oh yes, absolutely. It's that champ, for instance, has, recommendations with regards to um, representation in media and better ways of showing what migraine can look like, different faces of migraine, even children with migraine, even old people with migraine. So I think that society has a lot to, kind of answer for and potentially to change. Um, and I think that sometimes it's like an acceptance thing. It's,
yeah.
people understanding that saying that they have a problem doesn't mean that they're complaining. Sometimes it's the way to get to a solution. And when you can figure out what that solution is, you're not going to be struggling nearly as much as you had been without saying what you want to get off your chest.
Right, absolutely. That makes total sense. And I would say to any men who are watching this now, or who watch it, once it's on our YouTube channel, that if you want to participate in not only the project we're doing right now, but you want to get involved in advocating for migraine, we are always looking for men who are willing to go on social media. I know that that is not something that everybody wants to do in our focus groups. Everything that is said in our focus groups is anonymized, but people do have the opportunity to do additional projects with us. And we would love to speak to any men who feel comfortable doing that. And absolutely no pressure at all. But if there are men out there who would like to do that, we would love that. I only have one question left. So if anybody has another question, or I just see one just came in. But if there's another question, just let me know quickly so I can sneak it in here. So a gentleman here is asking, is there any way to address migraine with employers besides invoking the Family and Medical Leave Act?
Yes, absolutely. I think, and this is what we do many times without invoking the Family Medical Leave Act, is we ask for reasonable accommodations. Sometimes that's just a formal letter that comes from your, whether it's a headache specialist, neurologist, even primary care doctor, somebody that, in some states have to describe the condition. In some states, you're actually not allowed to describe the condition, and all you say is that, John Smith is experiencing a, painful neurological condition. And based on my medical assessment, it is necessary for, him to, then mention what the accommodations are. If they're deemed to be reasonable accommodations by the work, in other words, they say, yes, we feel these are reasonable accommodations, then they will let you have them. Sometimes they'll push back, and sometimes it may actually become somewhat of a more legal issue. And sometimes you do need to formally, get, legal, people involved. That being said, depending on what the accommodations are, usually it's something along the lines of remote work or remote work on, 1 or 2 days a week. Adjustment of hours. Sometimes it's so that way you're not commuting during, high commuting times, coming in early, things like that. Coming in late, staying late, different, like I said, reasonable accommodations, having the ability, let's say you're working, in an office setting, having the ability to go to a dark, quiet room for, a specific amount of time. Maybe we'll say, 30 minutes to an hour during an attack, so you can take your, medication or treatment and, rest and then come back to work, afterwards. There are definitely, some workplaces where they just, almost won't accept anything, even when it comes to, FMLA forms. And it's definitely, tough sometimes working with those kinds of employers. The majority understand, it's something that, we would talk about, your kind of medical professional and yourself. We would say, okay, this, you're asking for this. This is, what would likely be approved. Let's ask for what's going to be approved. And there's usually a lot that we can get out of it.
Right, absolutely. And for those who need a great resource on this as well and want to dig deeper, you can go to Migraine at Work as well. And that also reminds me that we have Migraine at School for people, parents of boys as well as girls who have migraine, and you can look at the things that they're doing there. I know that 2 of my sons had 504 plans. There are easy accommodations that you can ask for, whether it's wearing sunglasses, the ability to drink in class, drink water in class, wearing a device such as Neura. I know a lot of young people are wearing these devices, so asking permission to wear those devices in school and not having to go to the nurse, and many, many other accommodations depending on what is most needed for your child. I know the National Headache Foundation also has a project on college kids as well. And so whatever stage of life you're in, we do have resources for you, not just my organization, but a lot of other advocacy organizations. I can ask you one more question and then I'm going to close. So the question is, I know that we didn't really cover this, but there are other types of headache disorders, and some of them are more common in men. Could you maybe briefly just go over them and speak to the importance of getting an accurate diagnosis?
I would say the number one diagnosis to highlight is cluster headache. And cluster headache oftentimes is misdiagnosed in men. Many times, like we talked about, men, aren't always coming in to get diagnosed. And unfortunately, because it's more of a male predominant type condition, many physicians, even many neurologists, are misdiagnosing their patients with migraine instead of cluster headache. It also happens on one side, but it's exclusively on one side. The associated symptoms, instead of it being things like light sensitivity and sound sensitivity and nausea, are autonomic features. So it's tearing, or your nose running, or feeling very stuffy, sinus issues, ear fullness, swelling of the eyelid, sometimes your pupils changing. So one of a whole host of these autonomic symptoms. These attacks generally last anywhere from 15 minutes to 3 hours. And the reason why they're called cluster is because they will happen over the course of a month or two, and then they just go away. When they happen multiple times a day to every other day. So they can happen sometimes 8 times a day or sometimes, slightly less frequent, and they are extremely painful. Pain scale wise, they're generally somewhere between a 6 and a 10. Most estimations of the kind of pain that people experience estimated as higher than passing a kidney stone, worse than pain associated with childbirth and labor. And it is thought to be one of the worst experiences of pain that anyone can experience, that human beings can experience. Patients don't feel tired or the need to lay down and go to sleep. Instead, they're extremely agitated. Sometimes they're smashing their head against the wall. They're doing anything that they possibly can to get it to stop. This is a predominantly male to female, headache disorder. That being said, many women are misdiagnosed with migraine, and they really have cluster headache too. So it's important to get the appropriate diagnosis, and the things that treat one kind of headache oftentimes do not treat the other.
Right. And you may also have both, right? And so understanding that you have both is key, I would have thought.
Migraine tends to shapeshift a lot, but it's pretty uncommon for somebody to, I'm not saying impossible. Sometimes there are, secondary causes for these, cluster attacks to happen also. And migraine itself is very, very common, but most of the time, it's definitely worth talking to your, headache specialist, but the vast majority of people are probably going to have one or the other, or it's possible to have something that looks a little bit like a hybrid. We call it hemicrania continua.
Right.
You have, attacks that have those autonomic features. They generally will last a few hours. Today's look like migraine, but they're also only on one side, and that has its own treatment that's totally different than what you would use for migraine or for cluster headache.
That's really interesting. You just taught me something about that. We see a lot of people in our group who say they've been diagnosed with both. Or we have people who say they have cluster migraine, which always just makes me, kind of cringe, because we know there's no such diagnosis as cluster migraine. So that's interesting that you're saying that it's not common to see people who have both cluster headache and migraine as an actual diagnosis. So if you have been told that you have that, maybe check with your doctor, get a second opinion, because as Dr. Berk said, the treatments for them are different. So it just in the closing, yes.
Exactly, not impossible, but definitely, worth thinking about whether that's truly what's going on.
Right. Yeah, and I think that in itself just speaks to, the complexity of migraine, which is the condition I know much about, is that, it shapeshifts. I kind of describe it as an AI thing. Like as soon as you figured out how to manage it, all of a sudden it shifts and you have to do something else. And so, it's very interesting. We did get someone who just commented that they're being diagnosed with both. I find that fascinating what you say. And very, very interesting. So as we close, what is the most important thing that you would like to leave with people as we wrap up this webinar about men with migraine breaking the silence?
I think that it's to break the silence. It's to be open about what you experience. And that doesn't necessarily, in the way that is authentically, you and yourself. And it can be purposeful. It can actually allow you not just to break the silence, but even to break the cycle of worsening attacks, creating, a situation where your frequency continues to worsen itself, and then your headaches are, become very, very difficult to treat.
Absolutely. Thank you so much for that. And thank you for your time. And thank you everyone for joining us today on Migraine Meanderings.